He is our medical director for the Academy. He is my medical director as far as some of the things that I do in my office and in Dr. Glaros's office. He has been a past president of our organization, as well as several other organizations real involved with alternative therapies through the years. I am honored to have him come talk to us today, Dr. John Parks Trowbridge.
Hey, thank you. Thank you a bunch. So, well, I'm struggling to get there it is. Got everything started. So, first of all, I really appreciate your coming today. It is a rare privilege and pleasure for me to be able to address the American Dental Association. Thank you for this opportunity. Oh, wait a minute. Wrong slideshow. I'll correct that. I have been blessed today to have members of my staff come and help put materials out for you to just have something as a take-home message in addition. So if you guys will just stand and say hello. Here's Miss Lucretia, Miss Kathy, Miss Renee. These are the folks who make what I do doable. And there's 3 others who weren't able to come in today, but these folks, they just shouldered the load, which is what they do all the time in the office. Speaking of in the office, when you're going to a dentist, you kind of have to deal with whatever the dentist says you've got because you can't look in and make any sort of reasoned determination. And so when you've got a sore tooth, a hurt tooth, you want any dentist who can handle that. That's no big deal. But, we've got preventive dentistry as well. We've got the opportunity to keep those things from happening and even better ways sometimes to treat them as restorative dentistry. So the question is, when your tooth is hurting, do you want the best dentist or a dentist? Well, if you have to wait 3 weeks for the best dentist, you want a dentist. But when you have the option, you might want to get the best dentist for the restorative claims that you want to have. Now, what about other important things like, your health, your life, your heart? Do you go to the very best doctor? Who goes to the very best heart doctor, period? There you go, there's one. I got one. All right. And so why would you settle for less than best? You want the best in this hospital? Do you want the best in this town? Or do you want an Olympic champion? Because, see, ultimately, the risks are pretty high. Ultimately, the issues are pretty serious. And so we will often claim, I've got the best doctor. And, of course, the story on doctors. All doctors are money grubbers except for mine. Mine's a really good doctor. How do you know? Well, okay, I'm going to give you 2 take-home lessons today. Number 1, inflammation. Number 2, infection. And there you go. That's it for heart disease. Okay? But if your doctor isn't addressing those, we have an issue, don't we? So I'm going to talk with you about the top 5 reasons to doubt your heart doctor. Well, you're not supposed to doubt your doctor. You just take what he says as gospel, since he's obviously handing it down from on high. The only problem is you're not necessarily going to get the best that you need. Does your doctor actually deserve your trust? Well, there's a little transference thing in medicine. You kind of have to give your doctor your trust. You kind of have to believe that he's working in your best interest. But maybe he's not quite working in your best interest. Could he actually be lying? Could he be ignorant? Who believes the whole cholesterol thing now? The cholesterol is real important. We've got to lower your LDL cholesterol. Is he lying, or is he just ignorant? Or is he arrogant and ignorant, which is the worst combination? He could be lying, but it's not obvious because the only nose changes they get are the red ones as they get large from drinking too much alcohol. Could be he's just ignorant, like Will Rogers said, everybody's ignorant only on different subjects. Well, the problem is if you're going to a heart doctor, you do not want him to be ignorant on that subject. And therein lies the rub, because your doctor doesn't have angel wings. He doesn't have a halo. He does have prestige and respect. but it's only your life that hangs in the balance. Now, is that balance important? Sure, because, if you're not really liking the results you get, we ought to talk about going for a second opinion. And of course, if you don't like the second opinion, go get a third. Keep testing till you find one you like. The only problem is your cardiologist better be right, because he doesn't get buried in your casket. Now, I'm not supposed to do heavy emotional things, but then again, this is a pretty heavy emotional outcome if your heart doctor's wrong. So here's a question: why do doctors miss the risks? This is pretty serious stuff, because this wonderful football star dropped dead from hypertrophic cardiomyopathy and an associated arrhythmia. And we're talking about people in the best of condition, right? But he obviously had a heart problem. Now here's the real deal. One study screened 30,000 plus folks, and of the 159 who were disqualified at the end of the screening for heart reasons, consistent proportion had shown innocent or negative findings on their EKG. Now, that's interesting, because technically they should be disqualified so they don't end up at the morgue, right? So the only way you can actually really know about things like this is for you to play patient. You've got to actually present to the doctor and say, here's my situation, here's my activities, whatever. I just want to make sure that we're on the same page, that I'm okay because I can't see it from the outside. Or you could go to a play doctor, and our TV stars give us a very interesting impression there. Not all Marcus Welby's and stuff like that, but we kind of transfer that idea to our doctor. But what you really need is a studious doctor. You need someone who can be the doctor, who reflects on your situation because he has a technical background and expertise to understand it. He is not clueless. And in actual fact, it's very easy to find out whether your doctor is clueless. You start asking questions. And when the questions get a brush-off answer, a casual answer, you've already reached the limits of that knowledge base. Now, there is a solution for that. We've got a prescription for you, okay? And indeed, that's what a lot of people get, is a prescription. Well, what the heck does that mean? Well, just remember this. What do you call the doctor who graduated last in his class? Yeah, you got it, doctor. But, we don't wear a little tattoo that says first, upper half, last, whatever. But there are scientific facts that can uncover the truth, because here's kind of your choice. Withering like most of what life looks like in the richest, most knowledgeable nation in the history of the planet, we have pathetic situations instead of robust and vital situations. Now remember, you can break the law. You don't get caught, right? I would not break this law, because this is nature's law. Nature and nature's God will always win, regardless of how you rail against the heavens and whatever you think about it. There are natural laws. Well, those are the ones that we should pay attention to. Should we always trust the medical studies? There's an Australian journalist who says that about 2/3 of the published findings are refuted within a few years. That might actually be an understatement. What about, as he also says, as much as 90% of the physician's medical knowledge has been found to be completely wrong? Oh, wait a minute. The knowledge base. That's what your doctor is using to take your situation and make determinations for you and prescriptions for you. Well, the diagnosis can be so wrong that it causes you harm. Whoa, I didn't go to the doctor, first do no harm. I went there to get better. Well, the only way to get better in my ideal thing is to say, doubt your doctor. In other words, you've got to really have some understanding about what's going on for you, to you, and with you. So we're going to present the 5 reasons why you should doubt your doctor, and then we'll present how to solve those reasons. Now, it takes some reflective thought. You can't just make the appointment and show up. And in fact, that's the chapter in the Mastering the Art of Success book talks about how to get the maximum result from your doctor visits. But the thing is how do you know what to doubt? That's where it gets interesting. You should doubt your doctor because of the tests that they use, the drugs they recommend, the operations they propose. They're clueless about inflammation, and they're clueless about nutrition. That's a problem. So when you start doubting about the tests, remember the most important test is the history. Excuse me, don't really have time. We're running a little late today. All right, now what is it? Okay, good. It turns out that doctors in one study in North America interrupt the patients within 23 seconds from the time they show up. Start telling their story. Okay, 25% of the time, doctors never even ask the exact reason why you're here. And an average of 1.3 minutes to explain any sort of treatment issues. The doctor thought they spent about 8 minutes, and indeed the patient's left confused. An EKG is normal until it's not. My closest example in my first year in practice was a fellow who came in, and it was around lunchtime, a little after lunch, and he just gave me this story, and so I got an EKG on him, and I looked at it, and I go, your EKG is normal. I don't know, it's something about your story. When you see a doctor waffling, it's because he's trying to figure out what the hell is going on. And I said, why don't we do this? Why don't I put you in the hospital? We'll just keep you overnight and make sure everything is okay. So I put him to a monitored bed right down the hall from the coronary care unit. And at midnight, 10 hours after I had seen him, he infarcted. Now, a heart attack in a monitor bed right down the hall from a coronary care unit is almost ideal. The only other way you do it is actually be in the coronary care unit, which he was in about 2 minutes. Okay? And they immediately started all the protocols, called me up, and I said, absolutely fantastic. Get him a real heart doctor for the morning, okay? Is the EKG just squiggly lines? We have to remember the nurses in the CCU are looking at these squiggly lines and going, oh, that ain't right. All right? But that's because they can see significant changes happening. When you just get routine EKGs, there's a lot of disagreement in interpreting them. Angiograms are even worse. But it turns out that EKGs lack the necessary sensitivity and specificity to really be a standalone test. It is, however, an arbitrary gatekeeper. It turns out that only 66% of the later proven to be heart attacks, acute crises, were identified and advanced to the next level of care in an emergency room study. So they got to come back when they're worse off, as we say in surgery. All situations declare themselves. They either get better or get worse. Of course, when you get worse with a heart attack, you might not survive. So when they came back, okay, good, now we can take care of it. And it turns out that the more senior your doctor, the more likely you're going to get accurate understandings of the EKG. Literally a 6% increase in every 5 years of practice. In other words, the more senior ones have actually seen it all, done it all, and now will do it better for you. Now, in defense of the clinical setting, this is a story that came out of Dr. Group's book, and it says, how do you know the right thing to do? Alex Orkin asked, his voice high with elation. The point, of course, was that I didn't know. This is his senior attending doctor, and he were forced to make our decisions under conditions of uncertainty. This was medicine, not physics. It's a realm often of educated guesswork rather than arithmetical precision. I want a good guesser working for me, don't you? Stress EKGs, they stress you, and they can be falsely abnormal. Some people don't actually survive. That was not the right test to jump to, and they don't actually get off the treadmill still standing up. But what if it's falsely abnormal? Here's one example that one heart doctor says you can only move the probability of a problem up or down with the stress test. So it's not confirmatory, but it's suggestive. Treadmill stress tests, the thing is you shouldn't consider these in isolation for half the women and 25% of the males with reversible perfusion defects. That means important blockages, okay? We'll have a normal exercise stress test. Well, that's good. You mean, Doc, I'm okay? Yep, your stress test is normal. We're back to whether you want an Olympic doctor or the best in the city or whatever, okay? Coronary artery disease produces plaque in the arteries that may not actually be causing obstruction, blockage, which is what we're always looking for. You got blockage. But it's the non-obstructive plaques that can and do rupture. In other words, they break pieces free. Guaranteed, they will find someplace south that is smaller than they are. They will impact. Those little pieces of the plaque will impact and cause the heart attack. That means that a false positive or a false negative or stress test really does kind of impair the usefulness of this test. Often, it's the minor, not the major blockages that are causing the serious problem. Your life-threatening causes, okay? Now, this is a worrisome thing. You can pass a stress test and have a major heart attack the next day. All right, so it's not a perfect science. But what we're trying to do is figure out what's going on inside you so we can give you a better next day. So there is no one test. I have patients say, well, we did that other test. Yeah, I know, but we're looking around to see what we can define about how well it's working. One director of preventive cardiology says the surprising fact that all the research that describes stress testing has gone on for more than 40 years was done in men, not women. Well, that's kind of interesting because women are half the population. And incidentally, they die of broken hearts as well. Dr. David Newman says the test sensitivity for coronary stenosis, that blockage in the heart arteries, is only about 45%. Whoa, wait a minute. I thought we were doing this stress test to give me an answer, not a guesstimate. 45 cents is flip a coin. 45% is flip a coin. You're not looking for a flip a coin doctor. You're looking for a real answer. For every cardiovascular non-invasive test analyzed, every one they looked at, there's what's called verification bias. That means, oh good, your test was negative. I thought it would be. That's where we stop. Or your test was kind of positive. It wasn't exactly, I'm thinking that what we should do is the next test. In other words, you will interpret the test you see, verifying the truth you think that is going on. How about angiograms? This is really the gold standard. Well, turns out, despite the claimed safety, the incidents and deaths still occur. So what are the odds? Like it's 0 if it doesn't happen to you, 100% if it does, and incidentally, interpretations can vary wildly. What they did was kind of interesting. This is back, I think, in the 80s. They took 10 angiograms and 10 cardiologists and said, would you just read these? And we're looking for inter-observer, agreement and stuff. And then, first of all, they found out they couldn't read the same angiogram the same way. And then what they did is went back at the next meeting and said, we had some flub on the data. We need to redo the test, but we got different angiograms. And they were reading the exact same ones they read at the previous meeting. And the problem is they couldn't even agree with themselves. Not exactly the gold standard. What about nearly a third of the unexpected deaths occurred suddenly after a seemingly uneventful angiogram? What? Nearly a third occurred after an uneventful angiogram? Hey, yeah, okay. In 16 patients, the catheterization seemed uneventful, but death occurred within the next 10 minutes to next 10 hours. That's reassuring. That's why I had that picture at the very beginning. They certainly don't believe that the angiogram causes any problem that causes the infarct. So I'll just give you their answer. How about cholesterol confusions? Mainstream medical practice insists on lowering your cholesterol, even if it's just slightly elevated, and they scare you into it. But there's higher risks from the drugs than there is from the cholesterol. Let's talk about LDL, HDL, triglycerides, and coronary artery disease. And at this point, I'm going to switch to the glasses so I can actually see this here. Good. Of the people admitted with chest pains in a major emergency room with heart disease, okay, the lipid levels, LDL was 104. Well, no, wait a minute. They're trying to shove it down below 100. Now the new standard is they really want it below 75. But it was already just 104, 105. And before admission, only 21% of the patients were receiving lipid-lowering medications. Well, then how did their cholesterol get down like that? It's because it doesn't mean if you have low cholesterol, high cholesterol, you're going to have a heart attack. Now, higher LDL included people who are women, no diabetes, history of high blood fats, no prior medications, presenting with an acute coronary syndrome. Well, of course, because this would effectively be unsuspected, untreated people. But almost half of those will have an admission LDL level below 100. Remember, they're hospitalized with coronary artery disease. And the patients have an HDL level, about more than half of them below 40, which is certainly a risk because that's considered the heart protective cholesterol. But it turns out that what they want to do is, even though these folks are coming in with pretty low LDL levels, let's lower them even more. We're going to address that shortly. How about thyroid? Massively misunderstood hormone. Probably the most essential of all the hormones. Misinterpreted, rarely useful, misinterpreted, sometimes helpful. It's like free T3. It's early ordered. But that is the active thyroid hormone. That's the one that's going to keep you safe and well. TSH, oh my Lord, do I have to talk with patients? Because my doctor says you've been over-treating me with thyroid. Why is that? I've got their numbers, okay? I'm looking at it, and I'm looking at a good patient. Well, because the TSH was so low. Doctors do not understand certain things about their medical practice, but they give you their conclusions freely. Wilson's temperature syndrome is a problem with the tissues not properly managing the conversion to T3. That's a whole different thing than your blood levels. So let's go to the next step. Why should you doubt your doctor? It's because of the drugs. How about diuretics? Magnesium and potassium are depleted by diuretics, except for some of the diuretics which will raise potassiums, unless I had one patient who put on a potassium-sparing diuretic as they bottomed hers completely out. It was very profound and very interesting when you look at it. Well, these are critical for heart function. They're rarely checked or properly replenished. And that's just clinical experience. I just see these patients all the time. Now, magnesium depletion in clinical practice is related to specific diuretics, and patients treated with diuretics, more than a third will exhibit low magnesium levels. That's associated with arrhythmias and sudden death. How about the hypotensive fog and falls? And their insistence that your blood pressure has to be so low, because, you could die of a heart attack. What you do is you die falling into something or fainting out, or your brain doesn't work and you make bad decisions. Tight control might be the wrong control for you. And I let my patients, the older they get, float just a little bit, because the elasticity of the arteries has been compromised by their age, their nutritional depletion, their toxicities and such. And those folks are starting to get in trouble because the heart doesn't have the assistance of elastic blood vessels. It's got to do all the work. A little bit higher blood pressure allows the brain to get the blood flow it needs. How about fainting fog? Cognitive decline in the elderly is associated with lower brain perfusion. Duh. Okay. And in the studies, cognitive performance, that's your thinking and doing things, is better in individuals with a higher diastolic blood pressure. That falls under the category of Sherlock. Really? Okay. Statins subvert your health. In their insistence for brutal reduction of cholesterol, doctors prescribe ever stronger drugs at ever higher doses and require frequent unnecessary blood monitoring. You require really 3 good lipid profiles in your life. One, if you're a kid, you have some illness or injury and you're not healing the way you should, or there's something else going on, let's get one and just make sure genetically you're okay. One when you're about 20, so you've gone through your developmental years, let's see kind of where you show up, okay? And one when you're about 45 to see how much sugar and starch you're eating. And that's about it, okay? Cholesterol is not the culprit. LDL is not the devil that it's portrayed. Many heart attacks occur in patients, as I showed you earlier, with target levels. They're not even on statin drugs, but the drug side effects are real. Now, the problem is the doctors think we're crying chicken little. The sky is falling. The statins are bad. But they are bad. They are damaging. Every cell of your body requires cholesterol. It's the outer wrapping, the inner wrappings on the organelles. It's what makes the CoQ10, which is the queen of the energy production pathway. It's what makes your hormones. It's what makes vitamin D. Go through the whole list. You need it, but statins shove it down. It's kind of like the coyote dropping the anvil. He's planning to hit the roadrunner, but for some reason it always ends up hitting him. Now, I want you to think about that, because I really would like you to think you should doubt your heart doctor. Let me give you a twist of thinking. What if LPA is the flex seal in your arteries, okay? Because they talk about, oh my gosh, these patients have high LPA. Well, okay. They want to lower the LP. It's actually LP little a, but that's just extra words and I don't have time for it. If you have the understanding that animals like us that don't make vitamin C will raise their LDL levels as a protector of their blood vessels, because that's what vitamin C does. Artery disease, we call it, atheroma and arteriosclerosis and hardening the arteries. That is scurvy in your arteries, okay? That's scurvy. Well, as you do damage there, vitamin C helps cover that up, protect it, and keep you going. And if you don't make vitamin C, like we don't, and you don't take enough vitamin C in by mouth to raise those levels, you'll raise Lp(a). Why? Because it's a flex seal. It protects that area. And rather than jamming that down, which lowers your protection, maybe we should let it be up and realize, let's use this as a diagnostic test and really monitor how well you're doing in terms of your oxidation potentials. Remember, these lectures have been wonderful. Tom Levy just set everything up for me. Nathan Bryan did the same thing. This is a wonderful meeting because we're talking about real life, okay? And we want to prevent lipid peroxidation. So LPA really is the flex seal, and elevated levels of this protein indicate patients with elevated cardiovascular risk. Yes, they're struggling. They've got scurvy. They're going to die if they don't fix it. So what they do is their conclusion is increased Lp(a) concentration may refer to the need for therapy. Yeah, just not statins. Okay, as an aside, this is kind of interesting. Carcinogenesis, well, that's associated with lack of vitamin C, but the production of human Lp(a), the results say Lp(a) might play a role in controlling tumor growth and expansion. In other words, if you've got a high Lp(a) and we're not finding anything that we can relate to your blood vessels, maybe we ought to start looking at whether you're using that to help protect against cancers. Side effects. Doctors don't believe a lot of them, okay? And it's really 0 to 100%. So when a patient asks you, you don't get it at 0. You do get it, it's 100%. And no, we can't pick you out of the crowd and figure out. Musculoskeletal symptoms are the worst things that happen with statin. There's a growing population of individuals who experience intolerable musculoskeletal symptoms with multiple statins. What that means is they're finally putting enough people on them to really define how bad this can get. Statins are associated with muscle wasting, elevation of the enzymes that work in both your muscles and your liver, increased risk of diabetes. And there's also been a whole bunch of studies with mixed results with renal function, neurologic function, and so on. All right, let's turn attention to why should you doubt because of the operations. A stent is like a Chinese finger puzzle. We stretch it out and put it in, and it expands when it gets inside. But to do that, we really have to blow everything up with the balloon first, which is fracturing that blockage disease. It's a brutal disruption. Little pieces of that will come down when you decrease the pressure on the balloon. They will find something south. It will create some damage down there. But that stress against the arterial walls does what? Create something that needs to be healed. But remember, you did that because you don't have enough vitamin C or Lp(a). Oh boy, okay. So we better have to repeat that procedure because we need more. The risks of sudden death with an angioplasty and a balloon increase with age. One study found the death rate from angioplasty was 4% or so in Medicare patients. The rate of reclosure, more than a third of the treated arteries close up within 6 months. Anybody know anybody who's gone back for angioplasty and gone back for angioplasty and gone back? Because this is much more common. Even though it doesn't work, what does the medical establishment do? They will go to great lengths trying to fix the fact that it doesn't work. Stent redos. The restenosis in clinical presentation is similar regardless of the stent type that you use. It remains a hazard and should be minimized. Oh, did I mention this is a cardiologist saying that? Okay. Bypass, unneeded. You're a ticking time bomb. We need to operate this week. But bypass surgery involves risks, 2 to 5% death rates. Grafts routinely block off. Repeat grafting is common. Not only does bypass not cure heart disease, it does not extend life. And after 10 years, the failure rate of these bypasses is about 75%. Major study in the New England Journal, more than 10 times as frequent in bypassed arteries is progression of the blockage. Wait a minute. I thought we were doing this because of the blockage. Yes, and now you're going to get more progressive of the blockage. A six-nation study published in 1990 found a person after bypass runs a high risk of stroke, severe cases of anxiety and depression, hallucinations, and bypass is more traumatic than virtually any other surgery. Reoperation. Angina heart pains occur in up to 20% of the patients. Wait a minute, we're doing this for the chest pains. Okay, but up to 20% in their first postoperative year, an additional 4% each year thereafter. A second bypass is required in over 30% of the patients. There's a higher death rate with reoperation, and the benefits diminish and the risks increase as the age goes on. Big disappointments. The Veterans Administration Hospital, these are reports in the 1980s, okay? At the end of the trial, 3 years later, the survival rate for surgery was 88%, and for medical treatment, drugs, was 87%. Now remember, these people are not getting chelation, they're not getting nutritional counseling, they're not getting the modern drugs that we have, they're getting drugs that are 30 years old, and they still were doing as well as the operated group. Oh, except for one thing, and that is they didn't have the perioperative deaths because they didn't have the operation. 10-year follow-up on the Cooperative Surgery Center patients showed about 80% of the operated groups and the drug-treated groups were still alive. Interesting. Death rates, about the same. In the 8-year follow-up of one study, they found that the significantly lower death rates in the medically treated patients than in the group that had surgery. Maybe surgery is a bit of a risk, so maybe that is something to consider. Progression of significant heart disease was more than 10 times as frequent in bypassed arteries. Side effects of bypass: pneumonia, hemorrhage, heart attack, irregular heartbeat, bursting wounds, reoperation. With each repeated procedure, the risks are geometrically increased. I'm not sure I want to be recommended bypass with this, but one cardiologist said it's just like Pringles, okay? This guy headed the Framingham heart study, the largest epidemiologic heart study in the world. He says, angioplasty is like a potato chip. You can't have just one. In the Emory study, 14% of bypass patients and 63% of the angioplasty patients required a repeat procedure within 3 years. Golly, I want you to give me a longer lease on life than 1,000 days, Doc. Help me out with that. EKGs, stress tests, and everything have now become loss leaders because, like I told you about EKGs and stress tests, maybe not, and you kind of advance to the next level and you find yourself in the funnel, and even patients who are not sick are being wheeled into the operating room where they can get pump syndrome. Now, heart-lung machines are primitive technology. There are residual problems. Everyone has a changed personality. But, during the first year after surgery, up to 2/3 of the surviving patients, did you see that little thing? Surviving patients. Up to 2/3 of them can have heart attack, stroke, heart rhythm disturbance, worsening high blood pressure, congestive heart failure, personality or mental function changes. Geez, that sounds like fun, okay? Post-operative mortality. While perioperative deaths are explainable due to the gravity of the disease, the intensity of the surgical procedure, it's kind of less acceptable to have post-operative deaths in the months and years later. And that's what happens. So maybe the surgery ought to be questioned. But why should you doubt your doctor who's clueless about inflammation? Remember I said there are two things you want to remember from this talk, the take-home points: inflammation and infection. So let's talk about endothelial burn. Doctors as a whole have a very primitive understanding of the pathophysiology of the development of arterial plaque. They just don't understand the inflammation processes going on. So I want you to remember this. Those lining cells are very, very fragile, very special. They burn with the chemistry of toxicity, and incidentally, sugar being one of the toxics. Oh, I hate that problem. I hate to say that too. Inflammatory blockage. Neutrophils can be rapidly activated by pro-inflammatory stimuli. They will migrate to the areas that are a problem, and they release a variety of cytotoxic molecules. Well, geez, that doesn't sound like fun. No, it isn't. But they're trying to get recruitment. They're trying to get the rest of the cells in that are needed for healing and repair, for managing either infection, inflammation, whatever. In other words, your body is doing something wrong? No, it's doing everything right. Remember this, the body never makes a mistake, ever. It has in mind surviving for the next 10 minutes. You have in mind surviving for the next 30 years. Who do you think should win in this little one here? I think if you don't make the next 10 minutes, your 30 years doesn't matter at all. So, the body does exactly what it's supposed to do in order to handle that. In chronic atherosclerosis inflammation, the protective function of the neutrophils gets impaired, gets directed against their own cells. You get progressive vascular injury, the endothelial dysfunction and inflammation and plaque rupture and all this. Wait a minute, that sounds like the evolution of heart disease. And remember, cholesterol is not the culprit. Fred Kummerow spent 70 years researching biochemistry and physiology of inflammation, creating endothelial injury and artery plaque formation. His book title, published when he was 100 years old, incidentally, Cholesterol is not the culprit. Oxidized lipids are the problem, not the cholesterol. In the concentration of oxidation products, rather than the concentration of cholesterol in the plasma, is what identifies stenosis patients. In other words, we're missing the point by not looking for the products of inflammatory processes so that we understand how to, correct and control them. Vitamin C being one of the important parts there. Air, water, food, life, just daily living, that's inflammation. Doctors promptly forgot their biochemistry and their physiology and pathology, and they don't study any of the pro-inflammatory toxins that are surrounding us constantly. So what do they miss? Inflammation. And if they don't treat the inflammation, you don't get treated. Drugs create inflammation. They're stoppers. They block biochemical reactions. They're aimed at interrupting specific things. And in many cases, they can aggravate the underlying inflammation. What's one good drug? Ethanol. What's it do to the liver? Well, the critical role of oxidative damage and inflammation in ethanol-induced hepatotoxicity. Might as well just cross out hepato and put cardiotoxicity, because all the organs of your body are challenged by an elevated level of a drug, ethanol being a drug. Lots of other drugs, and that's why they warn you about side effects. The yeast syndrome equals inflammation. Doctors are unaware of my Bantam best-selling book in 1986 describing in great detail how the imbalanced growth of yeast can create many or most of our patients' discomforts and diseases. So this is now the second lesson. Remember, inflammation is the first take-home lesson. The second one is infection. All right, what about the microbiome? We talk so much about the microbiome. We're meaning the bacteria that are infecting in your gut. But patients with Crohn's disease have much higher levels of the fungus Candida tropicalis, and it seems that these organisms work together in robust biofilms that worsen the intestinal inflammation. Interesting, because you can really treat a lot of these things like their inflammation and infection and control both. What about intravascular fungal biofilm? Pause on that for a minute. Because remember, you can't have bugs growing in your blood because you're going to die because you have sepsis. Well, we're having to rewrite the textbooks because the lingering infections can be documented circulating inside you. Now, doctors concentrate on the half dozen or so of the 8,800 bacteria that can infect you. They completely miss other kinds of infections, parasites, fungus, and so on. What about deep blood fungus? That's my term because I had to come up with something to explain this. We actually got a test 2 years ago where we could actually see in peripheral blood by DNA sequencing. So know what we got. Okay, we already had a mugshot on that one, so you know what this one is. The main contributing prokaryotic species in atheroma debris, that means in the blockage in your heart arteries, suggests a diverse and novel composition. Whoa, that means we got a complicated infection going on inside our bloodstreams. Phenoliformis mossii is one of them that's detected in the coronary hard plaque. Fungus in the heart, but what's it doing there? Maybe it's making the plaque. Maybe it's there and your body is making the plaque to protect against it. I mean, there's some interesting speculations here, but we do have to rewrite the textbook because we just did not understand what we were dealing with. Out of 15 patients, 14 had molecular evidence of eukaryotic and or polymicrobial communities. That means not just one thing, okay? In 2 postmortem coronary plaque samples, that was the evidence of the fungus. Protozoa and fungi, we don't have good tests that detect these, but they may play a role in arterial vascular disease or atheroma formation. Remember, inflammation and infection. The thing is that, you know, for years they've been looking for viruses that are causing the blockage or bacteria. They've not been looking at the fungus. I think that when you put it down, inflammation is infection, and that's immunity, and that leads to membrane damage and mitochondrial injury, and this is how we die. Immune inflammation. One test showed autoantibodies involved in cardiovascular events. Maybe these are then markers of immune dysregulation associated with cardiovascular disease. Here's where it gets good for the American Dental Association group here. The apical infections and periodontitis is inflammation. And doctors and most dentists are unaware of the research demonstrating persistent bacterial infections in the gums and jaw, also in the coronary artery plaque. Interestingly enough, just a personal report, the fungus that is found in dental infections can also be the same one found in the blockage disease. Doesn't have to just be bacterial things. Here's one. Apical periodontitis and cardiovascular disease. 13 of the 19 studies that were reviewed found significant positive association between apical periodontitis and cardiovascular disease. 13 out of 19. The conclusion is, you got to love these guys, okay? Although most of the published studies found a positive association, the quality of the existing evidence is moderate to low, and a causal relationship cannot be established. Well, that means if you don't look for it, you'll never see it. And if you see it, you won't recognize it. And if you don't recognize it, you won't treat it. And how can they do that? How can they do bald-faced lies? How can they speak like forked tongue? Remember also that hypoxemia is inflammation beyond sleep apnea. It's different than sleep apnea. And doctors mistakenly believe that a breathing patient has sufficient oxygen and that several factors in reducing this critical nutrient are ignored. And cellular damage is just critical because more than 60 diseases are associated with sleep disorders, and a bunch of them induce the hypoxemia. So what do? We give you CPAP, which means we're just, scuba diving, pushing room air into your lungs rather than oxygen, which is what your body needs. Now, sleep disordered breathing has significant associations with humoral factors. Wait a minute. Humoral factors, that's antibodies and things like that, including coagulation systems and the body's protective factors against all diseases. Hormonal imbalance, inflammation associated with just all of these hormones being out of balance. That's absolutely critical. How about insulin? We use type 2 diabetes. They're just an insulin sponge. The more we need their blood sugar control, the more we shove insulin in. Well, that's dose dependent because the more injected insulin, the increased cardiovascular risk and the worsened mortality. So we're going to keep you alive with something that's going to kill you sooner thanks to inflammation, atherosclerosis, high blood pressure, lipid abnormalities, heart failure, arrhythmias. Really? In 1940, we asked the question, can we poison the planet? And as we gradually transition from farm to city, the resounding answer is yes, we can. And we have done that just in our food chain most desperately, not to mention our water supplies, not to mention our air that we breathe and so on. But agricultural products are the unspoken problem in terms of our exposures. Roundup equals inflammation. Glyphosate might be the most significant environmental toxin. It damages so many systems inside us. We have fragile cells. And as a matter of fact, my think is that because of the way we've got these ideas in mind about, we're fighting all the bacteria and the fungus and all this stuff, the chemicals, I'm amazed that life even happens at all. It's a very tenuous balance. But Roundup brain, geez, do you know what? It provokes oxidative stress. Isn't that interesting? And the Roundup body, okay? Current safety standards for things like Roundup may fail to protect the public health and the environment. No kidding. Really? Don't forget mercury. Prominent inflammation, hypertension, heart disease, heart attacks and strokes. It inactivates enzymatic reactions and so on, decreasing the oxidant defense, which we've been talking about. Heart failure. There's a certain kind of heart failure that has a 22,000 time increase of mercury in the tissues of the heart compared to other cardiomyopathies. Wow. I wonder how that happened. Inflammation, lead, several adverse effects, inflammation markers. Whoa, wait a minute. We're saying that we can test for all these things. Did your doctor? Did he get a history that would talk in terms of your exposures? Probably not. You know, blood pressure, lead poisoning. You get the lead out, the symptoms resolve. Is that important? I think it is. Your doctors are clueless about nutrition. Okay, EKGs, they read mild diastolic dysfunction. That's an impairment of diastolic relaxation because it's an active process and you don't have the magnesium. Whoa, if you're short of magnesium and they don't know it, you continue to have an abnormal EKG. Magnesium intake is below the normal needed and related to an increase for subsequent heart failure. It is a way of predicting heart failure that's arriving. Hypertension. Doctors make two key blunders. They overtreat and they ignore magnesium deficiency and other nutrients that are involved, other contributing food factors. Hypotension control. There's concern over overly aggressive blood pressure lowering, especially the bottom number, the diastolic, and it may impair not just cerebral perfusion, as I was talking about earlier with brain fog, but cardiac, coronary perfusion. Evidence for the benefit of lower BP targets in hypertension management. There's less and less in my worldview. Magnesium definitely lowers blood pressure, and it can do it actually quite nicely. It lowers it, and especially in people with insulin resistance and prediabetes. That describes our society. What about angina, chest pains? Doctors, they jump to nitrates and other drugs, but they ignore how nutritional deficiencies create and contribute to the problem. How about magnesium deficiency is associated with chest pains, may contribute to further worsening arrhythmias as well. Anything that interrupts the detoxification pathways, the doctors are blatantly ignorant about this, including the drugs that they're applying. Now, if you have detoxification interrupted in your heart, that can be involved with drug metabolism, and it influences the effectiveness of the drugs they're giving. Yeah, but that relates to the survival of the heart cells during any kind of problem like ischemia. And, the idea of having enough protection against the ischemia matters. So, why should you doubt? It's because of the tests, the drugs, the operation. They're clueless about inflammation, and they're clueless about nutrition. So now for the good news in each of these areas, because I know you wanted actually a solution here, right? And so we can all jump for joy, be happy with that. You remember, what are the two take-home lessons? Inflammation and infection. So these all relate to doing that. So what is the solution? What's the best test? Well, Will Rogers said he always felt the best doctor in the world was the veterinarian because he can't ask his patients what's the matter. He just got to know. Okay? Well, actually, our regular doctors, our cardiologists and others act just like they just got to know. But, the hands-on physical is a dying art. That's what people used to do. Now you can actually go into the orthopedist who will order the MRI and never touch you until the operation. What about this? And what about attention to fungus on the toenails and lesions down on your feet? Well, now, wait a minute. Remember, inflammation and infection? You got to look at the patient. And the complete physical includes lots of things. This is just off the internet. This is my bright idea. In other words, we can see from the outside stuff that suggests what we should be looking for on the inside. Very simple test called the exercise tolerance. The master's double standard two-step exercise 60 years ago showed that it could tell you with a pretty good likelihood whether you have a heart issue going on or not, okay? The Echocardiogram, non-invasive and easy. This is sonar for your heart. You can look at a lot of the function going on. You can look at a faucet and say, does it work? Well, I don't know, all the pieces look there. You got to turn it on to find out. And indeed, that's what happens with echocardiograms. How about the ultra-fast heart scan? That's a neat way because you can find calcium dots on the inside and you can start, kind of surmising how far advanced these endothelial damages have become. Non-invasive diagnosis is really the key. Non-invasive, not the angiograms and such. That should play a preeminent role in diagnosing the treatment or diagnosing the problem and monitoring the treatment, because it really gives you a good idea what's going on without spending a fortune and putting the patient at risk. You know, the problem with evidence-based, you hear that, medicine should be evidence-based. Well, doctors blow their own horn about that, but they routinely ignore the facts and the studies that are inconveniently inconsistent with their bias. So, you know, among stable outpatients presenting with heart disease, most patients experiencing clinical events have measurable heart disease, but less than half of them will show any abnormalities on the functional tests. Interesting. Okay. How about unstable plaque rupture? Sadly, many doctors are unaware that that's really the mechanism for the heart attack itself. The higher risk for inflammatory degradation of plaque caps means you're setting the patient up for a risk of a heart attack because you didn't pay attention to that inflammation. Turns out EPA, fish oil, reduces the plaque lipids and can help stabilize advanced atheroma plaques. In other words, there's something very simple in the diet that can help be protective. What about hypercoagulability and high platelet counts? Well, you know, you can measure these by simple blood tests, and you can start saying, wait a minute, there's things going on here that are pro-inflammatory that we should be handling. What's the solution with drugs? Old-fashioned drugs are just too damn simple. We have to abandon those and switch to the newest, advanced ones and ignore the fact that they don't do quite as well as the older drugs did. Congestive heart failure, as an example, kills. It's been treated for centuries with foxglove, which is digitalis lanoxin, okay? It killed my dad. Now, why? Because his doctors refused to restart the lanoxin when he ended up hospitalized, prolonged for congestive failure. And each time I would say, if you don't restart the lanoxin, he's going to slip back into heart failure, which he did. And each time he was in the hospital with that, they put him on the 4th generation antibiotics for pneumonia, which he did not have. But, you know, it's protocol. Standard of care. Well, that doesn't work, okay? Don't forget that when we use several drugs at a time, that's an experiment. The drugs were approved one at a time, not in combinations. And so, you know, maybe we ought to think in terms of smaller dosages to minimize the side effects associated with any particular drug. Lanoxin. Doctors are unaware of the very few drugs for which brand is medically necessary. Lanoxin is a prime example because you can get dead. Coumadin, lanoxin, these are what I call picture window, bathtub drain examples, where you actually have to manage the patient, not just see them back in a few months or weeks or whatever. Picture window means you need to get enough dosage of the lanoxin in to be able to look out the window, but not so much that you get up and you can't see out the window anymore. So here's your target range right here in the window. And then the bathtub drain is, as it is seeping out thanks to metabolism and detoxification, you got to put in enough just to stay in that right golden range. That means you have to manage the patient. You also have to understand the physiology of the drug. That might be asking a lot. Recently, we've introduced new things, quick and easy anticoagulants. You don't have to worry about managing Coumadin, except for one tiny technicality. You really can't reverse these things. So you get in trouble, you can get dead very quickly, and we just watch you go. No statins. They've now got PCSK9 protein blockers. Very expensive, but very simple to use because you don't have to worry about patients taking the statins. It's an injection every few weeks. Denham Harmon warned in 1957, margarine disrupts the normal physiology. Butter is real. Cholesterol is not the problem. Why use a bigger, better statin that doesn't help the problem? We need reasonable targets, not rigid ones that, you know, have to go by the numbers. You have to go for the patient. We're not treating the chart, we're treating the patient. What about hormonal support? Go ahead, ignore that at your peril, because then your patients will suffer. Why? Broda Barnes showed 40 years ago, if your thyroid was off, you had a higher risk of heart attacks. 40 years ago? Good grief. I mean, why do we ignore these things? Here's a fun one, hypoparathyroid heart failure. Guy came in, severe impairment on the left ventricular function. And you know what? He had undergone a subtotal thyroidectomy some 36 years earlier. And indeed, they had taken out basically all of his functioning parathyroid glands so that by this time he no longer had any, and his calcium level was just bottomed out. You got to think of what's going on with the patient, not what you want to have going on with the patient. What's the solution with regard to operations? Well, evidence-based selection in the 1980s in the big centers showed 5 out of 6 bypass operations provided no survival benefit. And that's with the primitive drugs we had back then. Minimally invasive things are better if you're going to have an operation. They can actually not have to crack your chest open. Those options are being developed. They do require equipment and expertise. This is one of those situations, again, where you want to have the Olympic star, not just the best guy in the city. What about beating heart bypass? This was being developed when I was in medical school. It avoids the pump syndrome. It was developed 45 years ago. I mean, this stuff is not new. It's just that people are not necessarily trained in it, don't necessarily have the expertise to do it. Here's bypass grafts, 4 per procedure. That's a big operation. 30-day mortality was 1.8% compared to 4.8% in those who went on the pump. So the low operative mortality and the acceptable perioperative morbidities, why not do beating heart bypass? Well, you got to be trained in it. You have to have experience. What about external counter pulsation? That's where you put the air sleeves on your legs, and when the heart's relaxing, you blow that up, and that helps push blood flow through. It really helps a weakened heart to recover. Not very many people have something available. Doctors are clueless about inflammation. What's the biggest deals with inflammation? Smoking and ferritin. Easy blood test. Easy question, how many pack years have you been smoking? Basically calculated out. We have sensitive blood tests. They are good markers of inflammation, but you've got to remember that smoking shows the flames inside. The white cell count, the fibrinogen, and all these things. The duration of smoking is positively associated with increased markers of inflammation. Duh. I mean, this is not that hard. How about anti-infection treatment? Remember the take-home lesson? Inflammation, infection. The yeast syndrome and deep blood fungus infections may be absolutely the key. We've known about a lot of diseases we couldn't really characterize because we didn't know where they came from. So we put you in a cubbyhole, send you to that specialist, and they slap on cortisone or chemotherapy. What if what you have is the result of an infection, and what you need is proper infection control? These things are serious, and they will get us more and more. Active anti-infective treatment and elevated cholesterol level might be protective because it literally can wrap around the fungus toxins. So maybe you raised your cholesterol in order to keep yourself from getting clobbered by an infection-produced toxin on the inside. Yeast definitely targets your metabolism. It lowers your B6, your magnesium, your fatty acids. Wait a minute. Those are the things essential for cardiac function, for heart and blood vessels, all this good stuff. Don't forget biofilms and parasites. When I'm telling patients about biofilms, I go, this is not a hard thing to remember. Don't brush your teeth tonight. When you wake up in the morning and swish your tongue around, that's an increased biofilm, okay, because of the things that are growing there. All these things in dentistry can get us in trouble. Mouth matters, okay? It turns out that parasitic invasion is very likely causative of many of these things. It really is, in many cases, a deep blood fungus. I'll be honest, in the complicated patients, we have not found one who does not have deep blood fungus. This might be the most exciting vista in diagnosis and treatment now. Well, reduce exposures. Isn't that kind of obvious? You take off the shoe that's causing the blister, but in the rush, boom of current medical practice, we've got to take care of patients. We're so busy taking care of patients, we don't have time to take care of a patient. The one in front of us. That kind of matters because that person's depending on us. That person is trusting us to take care of their well-being. Well, why don't we tell them how to avoid things? The old story that you can't dry off with a towel if you're still standing in the shower, right? So why don't we find ways to effectively eliminate these things? Here's a good example. Ferritin. A 3-year study in eastern Finland. Above 100 micrograms per liter, the higher the ferritin level, the greater the risk of heart attack. The Mayo Clinic says that the normal range is up to 336. Doesn't that mean a greater than 3 times risk of heart attack? Yeah. And a ferritin above 500 micrograms can kill you 5 times more likely because this is a sensitive measure of converting to the acidotic metabolism. When, babies are soft and rubbery and smell good, and older folks are none of the same. As you shift from alkaline to acidotic, you make changes so that you no longer use transferrin as you're getting sick. You use ferritin. That diversion of ferritin is a good marker that we've got some problem going on. Remember that toxic heavy metals impair virtually all metabolic processes in every tissue, every organ. It's a stealthy attack. But if you don't suspect it, don't test for it, don't diagnose it, don't treat it, nothing happens except you get sicker. Don't you depend on your heart doctor to know these things? EDTA chelation therapy reduces the body burden of toxic metals, reducing the damaging effects of inflammation everywhere. And that's the real problem. If EDTA chelation fixed one thing, maybe two, okay? Well, that doesn't interfere with the economics of medical care delivery. But if it interferes by improving everything, we can't have that. That falls into the category of DMSO and a few other things like that. We don't want something that treats at the level of inflammation and makes you better. We have a drug for that, remember? We have a drug for that. Organic chemical toxins, you have to sweat them out. That's the Hubbard method. It's the only way to really move toxins from the body fats and the lipid membranes. Also extracellular, intracellular spaces. These things are poisonous while they're sitting on the inside. What's the solution with regard to doctors being clueless on nutrition? Well, Thomas Edison said the doctor of the future will give no medicine, will interest his or her patients in the care of the human frame, a proper diet, the cause and prevention of disease. Look at that last phrase, the cause and prevention of disease. If the medical literature has enough studies in it that I can present these things to you just as selections, that give you an idea that we know a lot about the cause and prevention of heart disease, and we totally ignore the treatment for it. Remember, life is consisting of all sorts of little pieces, but drugs are not one of the pieces. And yet, what does your doctor reach for? The drugs. What about intoxication by water? It's rare, but in the heat of summer, in the press of exercise or mowing the lawn or whatever, more often people are camels and they never drink enough water, or they drink too much and don't replace the salt. So you can't even by the simplest of things get in trouble. We have to teach our patients moderation and planning and understanding how to lead their lives. Fibrinogen control. OGen on there, I put in a little highlight there. The body is very smart and makes a lot of things just to have available, kind of like on the shelf for an emergency. So if you need fibrin in order to form a clot to stop bleeding, all it does is go, snips the OGen off, now you have fibrin. But what happens when you get older and acidotic? You have free-floating ones that just kind of randomly got snipped. Those are like teenagers looking for a rumble. So you can use oral enzyme formulas that degrade these before they can organize into a clot and reduces your heart attack and stroke risk. Blindness, gangrene, kidney failure, the list goes on. Magnesium. We are dramatically deficient in our modern diets. The effects of that are profound. And you know what? We can prevent heart attacks. We can reduce the extension of damage in a coronary care unit. Millie Seelig showed this back in the late 70s. And we still do not have all the heart protocols and the CCUs acknowledging that magnesium levels have got to be elevated because those patients do not need to extend those heart attacks. Vitamin B6, misunderstood by even a lot of folks. It is central across the broad range of metabolic processes, critical in the energy production. Coenzyme Q10, critical in the energy production. And that's the victim of statin drugs in any dosage, any statin. And yet we just casually do that. Oh, well, cardiologists recommend this brand because that's best. Well, wait a minute. Why did they recommend the drugs that got you in trouble with that to begin with? What about nitric oxide inducers? Beet preparation has been shown to increase the tissue and interstitial levels of nitric oxide, whose discovery as a physiologic modulator won a Nobel Prize. Maybe. Maybe if it's Nobel Prize winning, we ought to maybe think, my doctor ought to be at that level, Olympic. Maybe he didn't get the Nobel Prize, but he can read about it, and then he can incorporate that into my care about omega-3 fatty acids. They're essential for membrane pliability, integrity of metabolic functions, and they dramatically reduce things like the plaque lipids. It has an anti-atherosclerotic effect. It stabilizes disease that's already developed, and indeed it might help to dissolve those as well. Antioxidant deficiency, free radical suppression. Wait a minute. Remember I was talking about inflammation. and infection. And of course, infection relates to oxidant stress and free radicals. Cholesterol is not the culprit. The book is exceptionally easy to read. Kumaro really put this research, 70 years of research, into a very understandable thing. So, I get patients, I go, I see you're still taking the Lipitor. Mm-hmm. Now, did you get that book from Fred Kumaro that I talked with you about? Uh-huh. And did you have any questions about it I could help explain? No? Mm-hmm. And you're still taking it? Huh? Well, my doctor said I should. That's why I started this talk this way. He's lying because he's arrogant and ignorant. What can I say? Okay. Vitamin C, ascorbic acid. The original research by Linus Pauling has only been expanded. It works. It's a clear reduction of cardiovascular diseases. Vitamin E and tocopherols. Natural vitamin E has been shown to prevent or reduce heart attacks since the 1950s. This is not rocket science. Well, we were just developing rocket science then. Bioflavonoids, long misunderstood with regard to their interactions with vitamin C, other antioxidants, and the body processes. But you know what? That's really where we're going to find how to control inflammation, because those things are natural. In the Garden of Eden, God said, all of this is for you. We should start taking a hint. It's not the drug manufacturing companies that are going to give us the best anti-inflammatories. What about glutathione, the master antioxidant? It's essential and it's difficult to raise the intracellular levels, and it's important that we all pay attention to it. That's survival. L-carnitine, essential for the metabolism of fatty acids. Hey, listen, when we talk about metabolism and this, we're talking about function of an organ. If that metabolism is impaired, the function of the organ is impaired. If it's your heart, you're in deep pookie. Alpha-lipoic acid. It's essential for energy production, serves as a cofactor for lots of things. Actually, here's an interesting one. The protective role against pesticide-induced damage. Of course, none of us are exposed to pesticides, right? I remember back the food chain, which is really the silent killer sitting out there. Lipoic acid administration is a promising therapeutic strategy to cope with disorders suspected to be caused by the free radical oxygen stress generators, especially in the brain. Alzheimer's. Who heard of Alzheimer's? When we were growing up, did you hear people with Alzheimer's? No. And then starting in the late 70s, early 80s, we started hearing about that. And you go, we started using all these chemicals in our environment. That's oxidative stress in the brain. Maybe we should look for simple ways to reverse it, since you can't isolate yourself from the food. No discussion would be complete without talking about the deficient status of iodine in humans. Remember, the thyroid function is absolutely critical for your well-being. Herbals and homeopathics. We owe a huge debt to earlier civilizations who found ways to work this because they didn't have the advanced technology. Now, I'm thinking the advanced technology gets in our way of looking at solutions. The standard American diet is sad. Look at metabolic syndrome, diabetes. Alzheimer's is characterized now as diabetes type 3. Look at the prepared food diet. I tell patients this is very simple. What I want you to do is to go to the frozen food aisle in the grocery store. Look at the TV dinners and start writing down what are the entrees in the TV dinners. Then I want you to write down what are the vegetables in the TV dinners. And then I want you to look at the limited food selection that you're getting and what deficiencies must you be having. Even if those were replete with nutrition, which they're not, you would be deficient because of the selection. Standard American diet's got to go. We got to eat protein, eggs and meats and butter and cream and raw nuts and such. Raw nuts, a study in 1970 found you could cut your heart attack risk dramatically by eating nuts 5 or more times a week. There's probably several mechanisms in that, but an interesting suggestion since we're told to avoid those. Fungal infection and heart disease. Remember, I keep talking about inflammation and infection. Bacterial DNA is found in coronary artery plaques, and fungal DNA was found in 92% of coronary artery patients. Those plaques are variable. They have a bunch of things going on, a polymicrobial contribution to the chronic inflammatory etiology. This is not simplistic medicine. This is sitting down and thinking over what could be going on with regard to this patient at this time. What is the right next step? Because, see, fungus and heart disease, lovastatin for lowering blood cholesterol, one of the statins, actually kills fungus. Okay? Now, I have 20 minutes based on mine right here. I do. I've got an hour and 9 minutes. I have a 90-minute talk. Don't give me the 10-minute thing. Constantini wrote on fungal bionics in 1994. There is a known cause of arteriosclerosis that is fungi and their mycotoxins. 1994, this is not new information. Mice injected with a water-soluble fraction of the yeast candida, which grows in our gut, universally developed coronary arteritis, inflammation of their blood linings. Fungus and strokes and high blood pressure, well, you know what? Research into those pro-inflammatory processes, maybe we ought to think that the microbiome is really important and start paying attention to that. Fungal infection and heart disease, cholesterol, remember, wraps around the mycotoxin, making it less toxic to the body. So maybe those elevated cholesterol patients are not just vitamin C deficient, but maybe they're overrun with fungus. Eat eggs to avoid heart attacks. Study done in 1960 by the American Cancer Society that you will not hear about showed that people who ate more than 5 eggs a week had fewer heart attacks. And don't forget, one of the reasons we're short on iodine is because we were told to avoid salt. Hey, you can't eat salt, that'll raise your blood pressure. But we still eat salt. It's called secret. It's pickles, peanuts, pretzels, chips. We get a substantial salt load, but not the iodine. Water, best to drink small amounts frequently, not big amounts. That just goes through to the kidneys. You want to hydrate your cells. You want to do grazing and breaking the fast, breakfast. Metabolic syndrome is reducing the glycemic load, reducing the glycemic index, the ease with which sugars start to attack inside your body. Critical digestion and absorption. By the age of 40, people are already starting to show significant impairments in their digestive function. Well, it doesn't matter if you select the best foods in the world if they're not getting into you. And digestive function starts with chewing in the mouth, right? Gut microbiome, prebiotics, probiotics. How many doctors recommend when they give you the prescription for the ampicillin or whatever, do they give you an antifungal antibiotic to prevent the overgrowth and give you, after that, to take probiotics to restore a gut balance? Not usually. The gut microbiome, we know almost nothing about it, and that fungal biome might be critical. It might be the key determinant in how well you're going to do. We better start catching up. Supplemental oxygen. It captures and removes electrons that derive from the production of energy. And you know what? In medical school, we were taught 2 liters. You know what you need? 3, sometimes 4. 2.5 is a minimum. So even the doctors who are halfway getting close just kind of missed the mark. What about walking? Simplest cardiovascular tone, mobility, balance, basal strength. It's available to anybody, including the couch potatoes. Sleep. Why am I talking about these things? Inflammation and infection. All these things are related to having the inflammation under control and having a robust defense system. We need more restful sleep as we get older. How about stress strategies? Oh yeah, that's a good idea. That reduces the oxidative stress. Prayer, meditation, good hobby, good relationship, music and oral and visual stimulations that can key right into your brain. What a good idea. So the future is here. It is now. We have microcurrent devices that can help restore electrophysiologic balance inside, even for stuff we don't know about. Because when you find the frequencies that work and you use them, they work for you. How about harvesting mesenchymal stem cells? Well, I'll tell you what, gently processing these produces the package that performs. If you have any questions on that, ask my staff. They'll be glad to tell you all the lies I've told. No, they'll be glad to tell you all the stories of our patients' successes. These things are important to understand because it's real. It's available. You can reach out for it and get it. About 10 years ago, they were talking about doing stem cell injections into the heart itself. They'd run a tube in and go stick, tick, tick, and put your stem cells in and stuff. And that procedure could help for a few months. We need to really understand how best to get mesenchymal stem cells working inside our bodies. So I say, doubt your heart doctor, but trust yourself. You have to watch your weight, your exercise and sleep, and your food choices. That's a daily thing. Occasionally, check your blood pressure and blood sugar. That's pretty much it. Don't worry terribly much about the other stuff. You've got something else that'll become obvious, okay? So you do not have solutions you can trust with regard to the tests, the drugs, the operations, the inflammation, the nutrition. You can actually look forward to enjoying a long and healthy, vital life. That's what this is all about. And health is your greatest wealth. French physician Georges Clemenceau, premier during World War I, said, "War is too important to be left to the generals. I submit that your health is too important to be left to the doctors." What happens when your doctor's best isn't good enough? You know, close counts and horseshoes, hand grenades, shotguns. If he's not even close, you don't count. What if your doctor's not the brightest bulb? But he's on my roster, you know, on my plan. He's on my list. Really? So you'll spend more time planning your vacation than you will worrying about your medical care. What if your doctor's not conscientious? We all know a couple here and there who are really looking at some other parameter or some other important thing. When your doctor's best isn't good enough, you have to remember that based on data from 30 years ago, 98,000 Americans die each year from medical errors. It's much higher now. The lower limit of 200,000 deaths, preventable harm in hospitals, 400,000 preventable harm a year. Serious harm seems to be happening 10 to 20-fold more common than lethal harm. Well, I don't want to have serious harm either. Forget the fact that I don't want to die. The death rate among men is 48% lower during a hospital stay for heart attack. They're more likely to receive the treatments for it. They're more likely to undergo an angiogram. They're more likely to undergo angioplasty. Well, wait a minute. What happened to our mothers, wives, and daughters? I mean, well, come on, guys, what's going on? Maybe your doctor isn't as good as you trust him to be. Only about half of the patients who come to the emergency room make it to the emergency room with their heart attack, okay? But if 2.1% of those are misdiagnoses of heart attacks, we've got a serious problem that you're being sent home when you're actually there. You made it there, and now you have a significant problem that could kill you. Of the patients sent home with unstable angina, okay, 21 of those 22 records were reviewed. An astounding 86% were seen by an attending physician. That's a senior doctor who missed it. Okay, 29% of those patients were seen in the ER by a cardiologist. A third of them were seen by a cardiologist, said, "You look good, go home." They missed it. Of the 19 patients sent home with a misdiagnosis, 79% were seen personally by the attending physician. He missed it. These people are actually having the heart attack, not just being suspicious for it. So life's risks are real. They are real. This is not a game. This is a play game for real. What you know, but you discount or ignore as being true is lying to yourself. What you know that is false, but you act as though it is true, is lying to yourself. What you don't know, but you act as though there's nothing more you need to know, a lot of patients come in with that, don't bother me with the facts, is lying to yourself. But what your doctor knows and ignores or discounts as being true is lying to you and could kill you. Not him, just you. What he knows that is false, but he acts as though it's true, is lying to you and could kill you. But what your doctor doesn't know, but acts as though there's nothing more he needs to know, is lying to you and could kill you. So our professional challenge to remember, amateur practices till he gets it right. A professional practices until he can't get it wrong. So you should doubt your doctor because maybe that would save your life. Linus Pauling said the right molecule is the right healing. It's the right drugs, right operations, right alternatives, right information you need to make these choices for you. Coming in 2018 will be the book based on this. Is it worthwhile? Should we do that? Yes, okay, good. Coming thereafter will be the Doubt Your Doctor series. You know, I've been in this business long enough. I know the people who can write the one on gut and skin and so on. These experts will help raise the questions that you should understand in order to better doubt your doctor. So you've been a wonderful audience. Thank you so much. This has been a fun deal for me.